All right. So in the morning, we started with the first trim, and we said that it starts from the first day of pregnancy to the 12 weeks plus 6 days, right? Yeah. Okay. All right. So that's what we said actually. I can see some people are still joining, but of course we cannot be waiting for them. Yeah. Okay. So let's continue from where we ended. But does anybody have has any question to ask? Anything you want to ask? If you have a question, please ask. You're okay. All right. Yeah, okay, fine. Let's start then. So we go to the fetal heartbeat, and I asked you, what's the normal range for fetal heart rate? You remember? What's the normal range?
Say 120
to 160.
120 to 160. Okay, yeah, that's right. So we are saying that sometimes with normal pregnancies, the fetal heartbeat is not visible until the fetal pole is up to 4 mm. You understand? That is around almost 7 weeks. Yes. So failure to identify fetal cardiac activity in a fetus whose overall length is greater than 4 mm is an ominous sign. Failure to identify that the heart is beating when the CRL measures more than 4 mm, because once the CRL goes beyond 4, it means that the pregnancy is 7 weeks and above. Do you understand? So by 7 weeks, you're not seeing fetal heartbeat, even though we know it's an ominous sign, meaning the pregnancy is failing, but you cannot confirm at 7 weeks that, oh, this one, there is no heartbeat, so it's a missed abortion. So, mommy, go and let them remove it. No, we don't do that. At 7 weeks, you know very well that the heart should be beating, but it's not beating. So don't be quick to write missed abortion. Just write that heartbeat was what? Negative. And so the woman should repeat scan in 1 to 2 weeks time for viability confirmation. You understand? You are confirming viability. In as much as you are thinking it is missed abortion, you can also give the pregnancy the benefit of the doubt. You can, give some time to confirm. For all you know, the next time this woman will come, heartbeat will be there. Do you understand? So don't be quick to judge. But in your mind, you know that by 7 weeks, there should be heartbeat, whether transabdominal or transvaginal. Transvaginal, by 6 weeks and some few days, you should see heartbeat. But transabdominal, it's 7 weeks. Do you understand? All right. So the fetal pole is apparent on transvaginal ultrasound just after the 6th week of gestation. This mass of cells is known as so that's the fetal pole. Yes, by the 6th week, transvag, as I said, it will be there. So as for the 6th week, the fetal pole, you will see it by hook or crook by 6th week on transvag. But then the heartbeat, once you see the fetal pole, you should see the heartbeat. But there are sometimes that you see the fetal pole, but the heartbeat may not be that evident, even if you zoom it large. So sometimes you have to give yourself some few days or 1 week so that you can see it clear. But for 6 weeks plus about 5 days, Transvaginal scan, you should see the heartbeat. Like you should see it. Once you zoom it nicely, you capture it nicely, your machine is powerful, you should see it. Do you understand? So the bottom line is that on transvag, at 6 weeks, as you already know, the third sign of pregnancy appears. And that is what? The fetal pole. And once we see fetal pole, heart is beating inside. So you have to see it. But if you don't see it, give yourself some time, 1 week or 2 weeks for a repetition. As for transvag, 1 week is enough for a repetition. Transabdominal scan, give yourself about 2 weeks for repetition. iPhone, you are talking. Who is iPhone? Please join with your own name. Who is iPhone? I'm seeing iPhones. Okay, the iPhones are 2. And another one. Another one is also here. Okay, hold on a second. Yeah, sorry. All right, so usually you can identify rhythmic fetal cardiac movement within the fetal pool, although it may need to grow several millimeters before this is apparent. That's what I explained. Today, so this crown ramplant. So today, the crown ramplant is a universally recognized term, very useful for measuring early pregnancies. So the crown ramplant is highly warranted and is the single most accurate measure of gestational age. Do you understand? So if you are thinking of the first trimester, the measurement, the one that is very accurate, it is the crown ramplant, very, very accurate. So the midwives, they prefer the women doing the scan in the first trimester so that they can use that EDD for their books to use that EDD. When you come and do a scan in the second trimester or third trimester, the midwives don't like that EDD. You have to write it, but they use the first trimester one, which is with the CRL. It's very accurate. So after 12 weeks, the accuracy of the CRL drops. It drops, it diminishes, and it is replaced by measurement of the BPD. Because once you get to 13 weeks, you are no more in the first trimester, a second and third trimester. So once you get to 13 weeks, since you have entered the second trimester, we use the second and third parameters, second and third trimesters parameters. Do you understand? So, and one of them is BPD. So from 13 weeks, BPD is very accurate. But it also, the accuracy ends around 26 weeks there. Then a different one will also pick it up. So that's how it is. It doesn't mean that it is less accurate. So you're not going to use it. No, you have to use. You have to use. But for first trimester, the most accurate is CRL. And you cannot use CRL if the fetal pole is not in, or embryo is not seen, or fetus is not seen. You have to, once fetus, embryo, or the fetal pole is seen is a CRL. If there is none like that, then you go for what? The gestational sac diameter or the mean sac diameter. So only after 53 days is the fetal rump the most caudal portion of the fetus. Yes. So 53 days is almost 2 months, isn't it? At that time, you are going to see even though it's fetal pole, but you are going to see the head a bit distant, but not that distant from the tail, which is the tail, I mean the bottom part of it and the buttocks area. You'll be able to tell that here maybe the head and here maybe the bottom part of it. You understand? So after 2 months, which is 60 days, the fetal head becomes the most cephalad portion of the fetal cell mass. That's what I just explained. Yes. Caudal means the bottom end. Cephalad means the head end. You understand? So you'll be able to differentiate the head from the caudal, which is the buttocks area. Yes, you'll be able to differentiate it by the end of 60 days, which is 2 months. What is really measured during this early development of the fetus is what? The longest fetal diameter, and that's the crown rump length. Longest fetal diameter, that's the crown rump length. So it is measured from outer edge of the cephalic pole to the outer edge of the fetal rump. When we say cephalic pole, you see crown, about 3. So it's like we are referring to the head. That's crown, right? Then the rump is the buttocks area, where it's more or less like where the spine ends, where the spinal column, where it ends, the backbone, where it ends. That's the rump. So you call that place causes. So we measure from the outer edge of the head to the outer edge of the causes. Do you understand? So from the crown to the rump. Crown is head, rump is tail. So crown to the rump, that's why we call it crown rump length. This measurement predicts the gestational age with an error of plus or minus 3 days after 7 to 10 weeks. The error increases to plus or minus 5 days between 10 and 14 weeks of gestation. Do you understand? So what we are saying is that when you take a measurement using CRL and you get from 7 to 10 weeks, within that range, there is an error. The error is like confidence interval, meaning it's plus or up to plus or minus 5 days. Up to plus or minus 5 days. That's it. We mostly take it like the whole of the first trimester, so that you don't get confused. The whole of the first trimester, when you take a measurement, the error is plus or minus 5 days. 5 days, if you run 5 days up, it's like 1 week, right? If you run it up, it's like 1 week because 1 week is 7 days. So if you don't want to make mistakes, take it that way. First trimester, the confidence interval is what? 1 week. Second trimester, confidence interval is what? 2 weeks. Third trimester, it is what? 3 weeks. Do you understand? So when we say confidence interval, if I measure, listen, if I take my measurement and I get, let me show you something. If I take my measurement and I get 10 weeks plus 0 days, somebody can come and take the measurement and that person can get 9 weeks plus 2 days. Somebody will come and take his or her measurement and get 11 weeks plus, let's say 3 days. All these, are they not within 1 week difference? Just check it. Within 1 week difference. 10 weeks, the 10 weeks, let's say 10 weeks plus 4 days, like this. Then this is 9 weeks plus 2 days. This is 11 weeks plus 3 days. Meaning that confidence interval means that the measurement you got, when somebody also measures his or her own, it will be plus or minus 1 week from what you got. Do you understand? Plus or minus 1 week from what you got. That is first trimester. First trimester confidence interval. Take it like that. Even though we have differences with the JS and then the CRL, but for you not to make mistakes, take it as one. Averagely, it's plus or minus 1 week, the confidence interval. So if you got 9 weeks, I can come and measure and I'll get 10 weeks. 1 week confidence interval. Somebody will come and measure and get 8 weeks because you got 9. So it is plus or minus. Do you understand? Plus or minus 1 week. This is very simple. If you don't understand, let me know. So fetal flexion may decrease maximal crown ramp length. Yes. A fetus should be flexed normally. If a fetus is like this, flexed like this, it's okay. But if you get a fetus who has flexed like this, they are the same gestational age. If you measure this one up to this one, you get less. Let's say you got 9 weeks plus 0 days. When you come and measure this, you see that this one is not too flexed, and this one is a bit extended. So you may get around 10 weeks plus maybe 6 days or something. So you see that there is an error because of what? Excessive fetal flexion. Flexion means if the fetus hyperflex or flexes too much, the gestational age will be underdated. Do you understand? You may underdate the gestational age. But if it extends too much to you overdate it. So it should be normal. It should be normally flexed. And you can see it whilst you are scanning. If it's too flexed, you will see it. That is too flexed. Okay, all right. The femur can be measured as early as 10 weeks gestational age. The femur can be measured as early as 10 weeks gestational age, but we don't measure at 10 weeks. Take note. Femur, it is not for first trimester, but rather second or third trimester. Yes, Francis.
Sir, please, my question is, when the fetus is too flexed, how are you going to measure it to get the real gestational age?
Yes, so you measure when you check and you see that it is too flexed, you can tell the mother that please go and walk around in about 15 minutes time, come again and let me check. Do you understand? Sometimes the mother doesn't have to even go and walk. Okay. Sometimes as the mother is lying down, the fetus is moving, so it will now extend more and then you can measure. You understand? But
okay.
But sometimes too, there are people waiting. So if the fetus is not extending, to the level that you want, you can ask the mother to go and walk maybe for about 15 minutes. Go around the facility about 15 minutes and come back. By the time she comes, you check again, and it has got into the shape, that position that you want. You understand?
Yes, sir.
If it is still the same, you don't have an option. You can measure it like that. Yes, but that is when maybe some people, if it's around, let's say 12 weeks, some people can still, if you measure the CRL and you are getting it wrong, you can measure the FL to see if it will give you the gestational age. Yes, then you compare. But first trimester, we don't. You are just comparing it. You don't have to. You don't have to include FL in first trimester report. And first trimester is just JSD, MSD, or CRL. That's all for first trimester. So that's how you go about it. Just let the woman go and walk small and then come back, because at that time the surface area of the endometrium is so big, and the fetus is also tiny, so it moves like that. So anytime it can change its position. So fetal BPD and female length. For gestational age dating, they have confidence interval of, so I've talked about this. I said that even though this is how they are, the confidence interval, from 12 to 22 weeks, it is plus or minus 1 week. Then from 22 to 32 weeks, it's plus or minus 2 weeks. Then 32 to 41 weeks is plus or minus 3 weeks. But this one, it confuses people. So we have generalized it that for first trimester, it is plus or minus 1 week. Second, plus or minus 2 weeks. Third, plus or minus 3 weeks. That makes it simple. You understand? So that when you give an EDD, you tell the woman, oh, woman, please, you are going to deliver on the 10th of August. If you tell the woman that, and the woman put it in her head, know that the 10th of August, you scanned it. If you are using the first trimester EDD, then it is plus or minus 1 week. But if you are using third trimester EDD, know that it is plus or minus 3 weeks. So explain to the woman that even though the machine is saying you are going to deliver on the 10th, but it can be between, or let me say, it can be 3 weeks before or 3 weeks after. Do you understand? If you are using the third trimester EDD, when the woman came third trimester and you measured and you are using that EDD and it gave you 10th, then explain that it could be 3 weeks before, 3 weeks after. That means within. You understand? It's not like the 10th. So 10th, you are delivering. But if you are using CRL EDD, the person came first trimester and the report is there, CRL, the EDD is very accurate. It's not like 10th, no, even if it's CRL, that 10th, no, it doesn't mean that it's the same time that you're going to deliver. That one is plus or minus 1 week. Do you understand? So that one is more accurate than the third trimester EDD, which spans to 3 weeks confidence interval. Do you understand? So it's always important the patients come in the first trimester. That one, when we get to the second and third trimesters, and then I think I'm not the one who will teach you that to do. But if I will be the one who will teach you multiple gestation, you will understand. But that's how it is. All right. So determination of gestational age. I've talked about GSD and CRL already. So this is how to measure. Do you understand? So I told you that you capture the longitudinal section of the gestational sac. You capture the transverse. So the longitudinal. Have you seen that the sonographer has measured twice over here? Have you seen it? That's longitudinal. You measure it 2. Then you come to transverse and measure it once. Either you go left to right or top to down. They are all the same, just once. Okay, so this one, it is mean sac diameter. You have to go and select the MSD on your machine. And you come and measure 3 dimensions. Once you are done, the machine will give you the gestational age. Okay. Another mean sac diameter. There's the sagittal section, there's the transverse section. So the sagittal, you measure 2 dimensions, transverse 1 dimension. Okay, now at 6 weeks gestational age, embryonic structures and heart activity are almost always visible. Yes, at 7 weeks, the embryo is 10 mm at a minimum, and fetal heart activity should be visible in 100% of viable pregnancies. I think I've talked about this. At 7 weeks, you should see the heartbeat. Yes, by 7 weeks, I've talked about it. At 8 weeks, fetal structures are visible, and the yolk sac is identified as a circular structure measuring 5 mm in diameter. Yolk sac is seen at 5 weeks on transvaginal scan, but you can see yolk sac through 7 weeks, 8 weeks, 9 weeks, 10 weeks, you will still see it. But yolk sac diminishes, it vanishes when the placenta is coming. And placenta, you can start seeing the placenta at around 8 weeks. You start seeing the placenta. So as the placenta is being seen on the scan machine, yolk sac is also diminishing, because yolk sac, the function of the yolk sac is to come and produce or get nutrients or supply nutrients to the developing embryo. Do you understand? That's the function of the yolk sac. It feeds the developing embryo. So the moment the placenta is coming up, yolk sac is not needed, because at that time the fetal pole has grown to become fetus. Yolk sac is tiny to supply nutrients to the fetus. Do you understand? It can't supply nutrients to the fetus. The placenta has come, so the placenta has to do the job. So yolk sac will vanish, but it doesn't vanish one day. It's more like gradually, then it vanishes. Do you understand? So that is it. So the detection of a yolk sac excludes the diagnosis of blighted ovum, because a viable embryo is necessary for yolk sac development. All right, but not all the time though. When we get to blighted ovum, I will explain. It's not brighted, it's blighted, BL, but that name, it's obsolete. We are not using it anymore, even though the old midwives are still using it. We call it embryonic gestation. I will explain that when we get there. So you can see that this is the yolk sac, right? Yolk sac has blood flow. So you can see the color box on it, and it's showing blood flow on the periphery. That's the yolk sac. And you can see that, please, what do you think? What structure is coming from this place that is showing blood flow? What structure is coming from this place? Who can tell me? Where my cursor is, what structure is coming from there? Or is developing from there? Oh, you can see the blood flow. So what structure?
The placenta.
The placenta. The placenta, that's it. Yes, the placenta is coming from that side. That's why the vascularization is intense over there. Okay. So that's an embryo, a nice embryo. That's the gestational sac, and the gestational sac is there, black. The focus wasn't on the gestational sac, because at this stage, you are not measuring the sac itself, even though the person measured the sac, but we don't need the sac for anything, because if you measure a sac that is elongated like this, you are going to get wrong measurement. So we don't measure the sac. The embryo is inside, so CRL is what we have to measure. CRL. So we measure the CRL from the crown to the ram, from the crown to the ram, top here to down here. That's how we measure the CRL. Do you understand? So that is it. And who can tell me where the let me use this ink, where the placenta is coming from? This is A, this is B, this is C, this is D. Where is the placenta coming from? Who can tell me?
Sir, it is coming from where the B is.
The B, okay. The B, yes, and that's true. Where the B is. And the reason is that you can see clearly that that part is protruding towards the sac, right? It's pushing towards the sac, isn't it? It's clear.
Yes, it is.
It's clear over there. It's pushing towards the sac. If you put Doppler there, you can see flow, a lot of flow. That's where the placenta is coming from. So at this stage, the placenta is already there. So yolk sac activity is not needed. So it will shrink. Have you seen the yolk sac over here? This is the yolk sac. Have you seen this line? That is called vitelline duct. That's a vitelline duct. It is connected to where the placenta, the placenta is coming from. It's connected. Try to get nutrients and those stuffs for the developing embryo. Okay. All right. So in your exams, if they ask you the dots that connect the yolk sac to the uterine wall, it is called vitelline duct. Vitelline duct. Okay. So you can see the placenta is coming from this place. And what structure is this? Please, what structure is this? Where my Keza is, what structure is that? Oh, you can unmute and talk. What structure is this?
The embryo.
Okay. The embryo. Okay, that's fine. A second. Let me send a message to someone. Okay. All right. So that's the embryo. But we are seeing something. Inside the embryo, this structure here. What do you think? This structure, where my Keza is. Why is it flow of blood? Which part of the embryo is that? Is it the chest? Is it the head? That part? Is it the head, the chest, or abdomen?
Is the chest. The
is
chest.
the chest.
Where the heart is.
Okay. You could be right though. You could be right.
So the abdomen of the fetus.
The abdomen. Are you sure? No, that place is not abdominal. This place is more cephalad, like it's more to the head area. So it's more to the head. Even though the chest can be part, but I don't see the chest over there though, because the upper limbs are here. There's one upper limb. There's one upper limb. And then I think the lower limbs are also there. Yeah, something like that. So there's more to the head. The flow is more to the brain. Yeah, even though we weren't the ones who captured this image. Can somebody tell me why this is showing color flow, this structure? What structure is this? Who can tell me? What structure is that? Why is it showing flow?
Said the cord.
What cord is that?
Umbilical cord.
Okay, umbilical cord. So umbilical cord, that's true. So the cord. Oh, a second, please. Hello. Yes, sir, boss. Yeah, sorry. Okay, so yes, as we said, the umbilical cord, because there is what? Blood in there. I taught you guys what are the components of the umbilical cord. Emmanuel Oben, your class, answer this question because I taught you last week or this week, yeah, Accra. What are the components of the cord?
Membranes.
The arteries.
Membranes.
Vacuum gel.
No, wait. Artery, the artery, you have to qualify it. Is it one artery or what?
Two.
Two arteries,
Two arteries. jelly, and then membranes.
Watson's jelly, but I didn't hear about the vein.
So I said one vein.
Okay. So those who don't know, please, these are the components of the umbilical cord. These are the components of the umbilical cord. Very important. Oh, kindly mute yourself. Who are these people? Okay. So two arteries, one vein. Two arteries, one vein. If you are asked how many vessels are contained in the umbilical cord, you say 3. 2 arteries, 1 vein. Now we have Watson's jelly. It's like cream. It is protecting the 3 vessels. Do you understand? And the membrane is the one covering the cord, within which the Watson jelly is found. Do you understand? So that's it. It has started raining here. It's rained throughout the night and it's raining again. So let's pray the network is still stable. Now, have you seen the umbilical cord again? Please, what is this one? This, where my cursor is. What is this one?
Sir, the yolk sac.
Exactly, the yolk sac. Exactly. Yes. So this is the placenta here because the cord, the umbilical cord is there and it's supplying the fetus or it's 7 weeks, so not fetus, embryo. It's supplying the embryo. Embryo is 9 weeks. The moment it gets to 9 weeks, it's 9 weeks, it's an embryo. Sorry, fetus. Why am I combining things? Listen, once the fetus, the embryo gets to 9 weeks, it's a fetus. Do you understand? But embryo is the same as fetal pole. That one is below 9 weeks. Once it gets to 9 weeks, we don't call it embryo again, but rather fetus. Okay. Have you seen this? Please, what is this? This whole thing, what is it? Check the age and tell me then what it is. Oh.
Fetus.
Okay, fetus. That's a fetus, right? Okay, that's good because it is 9 weeks. Do you understand? It is 9 weeks. And I'm sure all of you, with the exception of the first semester students, you haven't seen this live on ultrasound machine before, right? But the second semesters, you have gone for attachment. So this one, you cannot tell me throughout your attachment, you never saw one. Then you didn't go. Then you'll be truthful to yourself that you didn't go. Because Ghana, how people are giving birth, getting pregnant every day. And you went for attachment for about 1 month or so and you didn't see this. Then you didn't go. So you saw this, and this is a fetus. And once you see this, the measurement is simple. You start from the crown. Here, you go and choose your CRL. Start from the crown and measure straight to the ramp over here. You are done. The limbs are not parts. The limbs are not parts. Please end at the ramp area. That's all. I hope you understand. All right, that's CRL. Have you seen how the sonographer has measured it from the crown to the ramp? Do you understand? From the crown to the ramp. Crown to the ramp. That's why we call it crown ramp length. Please tell me where the placenta is. I'm naming it. A, B, C, D. Where is the placenta? Oh, this one too. I need to mention names or what? Tell me where the placenta is. Is that where?
A.
A. So you say it quick and we move. That's A. Yes, that's the A part. You understand? It's very clear over here. The placenta is very clear over here. Nicely. Okay. So you can see the fetal head nice, right? Over here. The chest is here, the abdomen is here, and the lower limbs are there. But the focus wasn't on the limbs. The focus was on the from the crown to the ram, not on the upper limbs and the lower limbs. So physiologic mid-gut herniation. When we say physiologic mid-gut, anytime you hear the word physiologic or physiological, it means normal. It is normal. You see, in embryology, the study of embryological development, what happens is that before the abdomen forms, I mean the internal organs, everything forms. That cavity is so small for the formation because the formation involves a lot of steps. Sometimes they have to, they have to be creating some form of crooked movement and a whole lot. The steps is long. So the abdominal cavity is not enough. It's not enough for those steps to happen. So where we have the navel area, from one side, it's open. It's opened in embryology. That part is opened into the abdomen. So all the organs come out, and within the liquor, they now form. Yes, all the steps happen there because it's a large space. So it will happen there. After all the steps, the last step is for all those organs to move back into the abdomen. So this one, like this, it is physiologic herniation. It's around by 10 and 11 weeks, that thing is happening, and the fetal abdomen has moved out into the liquor area, the amniotic fluid. When we say liquor, amniotic fluid. So the fetal abdomen is out in the amniotic fluid, but it is there is a sac covering it like that. So all the steps happen there to develop the internal organs, the abdominal organs. When they are done, the last step is for the abdomen to move back into the fetus, and then that cavity in the abdominal wall, that corner down, that defect should close. It will have to close. So if it fails to close, that is when we have a condition called omphalocele, which you do that with a person who will be teaching you fetal anomaly, the anomalies, anomaly ultrasound. You do it. That one is when you do the scan by 18 to 23 weeks, and you still see the herniation. It is a pathological state. That means that there is a problem with it because by 12 weeks, even by 13 weeks, all these things are done. It should move back. You understand? It should be done and move back into the abdomen. So if you see it at 10 to 11 weeks, and you are seeing the fetal abdomen which has moved out, and it is in the liquor, it's not anything. It is physiologic, it's normal. It should happen for the development of the abdominal organs because of the steps it undergoes. Yes. So this is physiologic herniation. You can see the fetal abdomen in the liquor. That's the fetal abdomen here. The focus was on the abdomen alone. That's why you are not seeing the other parts of the fetus. The sonographer viewed the herniated abdomen alone. And you can see the cord. But the cord is at the navel area, the umbilicus area. That's why you see it continuous with the fetal abdomen. And that's where the herniation is. So there are some children, after the abdomen has moved back, instead of the cavity to close well, the skin will close, and then the other abdominal wall fails to close. So when you give birth to them, as they are growing, the navel is everted. and when they cough, you see that it is like a balloon. You understand? When they cough, yes, there will be some of the abdominal content pushing into it. Yeah, so it's a form of hernia that you have to send them for surgery. Sometimes as they are growing, it will close, but most of the time too, it doesn't close. Then they develop that F2 kind of. So you go and do surgery and correct it for them. Now, ultrasound detection of chromosomal anomalies. This one, most of the time, they don't teach. And this is the main reason why I asked all of you to join this. So, common chromosomal anomaly detection. How can you use ultrasound to detect chromosomal anomaly? How? You understand? So, we call something nuchal edema. Nuchal edema. But the real term is nuchal translucency. Very important. You cannot say you're a sonographer and you don't know nuchal translucency. Charity and your people, you have done first trimester. Do you know about this?
No, we don't know.
Really? You said who taught you first trimester?
Yeah, me that I don't know. Maybe they know.
No, like I mean, were you taught? That's what I mean.
Yeah, please, I've forgotten.
Okay, but all of you cannot forget. So if you have forgotten, please, is anybody here who recalls NT, nuchal translucency? If you have been taught. No one. Okay. So it means that, okay, so it means that you didn't do ultrasound detection of chromosomal anomalies. All right.
Yes, please.
So then I'm teaching you. Grab it. Because this one, when I was practicing as a sonographer, it really helped me. I diagnosed about 3, and all of them, 2 of them, the women said they are not going to terminate it. The doctor did all that he could. The women said no. Their pastors are saying, their prophets are saying, they are so and so and so. They didn't terminate. And as I'm talking to you right now, those children, they call them Nsuma. They gave birth to them too. And truth be told, they are like that Nsuma for Nibi. But it is not Nsubiaba. Nsubia Niba. Oh, baby. It is not Nsuba. But then it is chromosomal issue. Please. And that's what I'm going to teach you. Take notes, because you can help someone. You can diagnose it, and if the person listens to you, that person will not give birth to that child. Now, yes, Francis, I saw you raising your hand. Or
So now I want to see whether if I can describe the nuchal translucency.
Yes, we can talk.
My understanding is it is a fluid filled space at the back of the
Exactly.
fetus or the embryo.
Yes, the neck, at the back of the neck.
Okay, sir.
Yeah, that's it. So you see, there is perfusion. You and I, the heart is pumping, right? So we have blood running in us. Same thing applies to the fetus, the embryo or the fetus, right? Now, for those with chromosomal issues, some chromosomal issues, the perfusion is when we say perfusion, how blood is able to diffuse and give you oxygen and nutrients, that's perfusion. For those with some chromosomal abnormalities, the perfusion is hyper. There is hyperperfusion. And since there is hyperperfusion, it shows at the back of the neck in those fetuses. So you see fluid over there, we measure it. So when you are testing for nuchal translucency on ultrasound, we measure the fluid at the back of the neck. So nuchal translucency is measured. It's measured between 10 and 14 weeks. Please take note, between 10 and 14 weeks. So if the woman didn't come for scan between the 10 and 14 weeks, then you cannot measure nuchal translucency. Then you can measure between 15 and 22 weeks, and that is nuchal fold. Nuchal what? Fold. And the parameters are the same. Nuchal translucency, NT, is measured between 10 and 14 weeks. Then if you couldn't measure, then you wait and measure the nuchal fold. Maybe the person came 15 weeks or 16 weeks. That is nuchal fold time. You have to measure between 15 weeks and 22 weeks. That's where you measure the nuchal fold. So it's the same thing, the fluid at the back of the neck. But it's because of the gestational ages that the name has changed. Now, greater than 2.5 mm between 10 and 14 weeks is abnormal. Do you understand? That means that nuchal translucency, when you measure and it is more than 2.5 mm between the 10 and 14 weeks, it is what? Abnormal. But please, in practice, the 3 mm is the cutoff. So even if you get 2.5 mm, you report it. But the doctor knows that the cutoff point is 3. Once the person gets 3 mm, that means there could be a chromosomal anomaly. If it goes beyond 3, 3.5, 4, that one, there is a confirmed chromosomal anomaly. But you don't know the type of chromosomal abnormality. Do you understand? So please, the cutoff point is 3 mm. The cutoff point is 3 mm. Nuchal translucency and nuchal fold, both of them. Cutoff is 3 mm. You shouldn't go, it shouldn't reach 3 mm and also beyond. No. So edema is swelling. Edema simply means swelling. Nuchal simply means neck. So the easiest way to obtain the measurement is to do transvag and try to get a view of the back of the neck of the baby or the fetus. The caliper should be placed on the white line surrounding the nuchal lucency. The suspicion is that the nuchal translucency is due to over-perfusion. I explained it. Hyperperfusion of the cephalic end of the fetus. So the head part of the fetus, there is hyperperfusion of blood because of chromosomal issue. I'll show you how to measure it. Overall, about 30% of fetuses that have the nuchal translucency, one, have an aneuploidy. What is aneuploidy? Aneuploidy is abnormal chromosomal number. Abnormal what? Chromosomal number. How many chromosomes come together to form a human being? Who can tell me? How many?
46.
46. So the man will bring 23, right? And the woman will bring 23. 46. Now, aneuploidy means that there is abnormal number, either reduction or increment, abnormal number. So once we see nuchal edema and it's measured more than 3 mm, there is an aneuploidy. We don't know that aneuploidy, but there is an aneuploidy, abnormal chromosomal number. The most common aneuploidies will be trisomy 21. That's the one they call in Suba. We call it trisomy 21. The name is Down syndrome. Down syndrome, trisomy 21, very common among the chromosomal abnormalities. Trisomy 18, we call it the Edward syndrome. Edward syndrome, trisomy 18, is also a chromosomal issue. And monosomy X. Monosomy X is called Turner syndrome. Turner, 10 to 10. So Turner or Turner's syndrome. That's monosomy X. Now, these conditions are all chromosomal issues. So instead of let's XX, oh, there's red. Instead of, please, XX is so we have XX. XX is a female or male? XX.
Female.
Female, good. So instead of XX, the man is bringing 1X, the woman is bringing 1X. Women only have X, right? You will see that 1X will be deleted, remaining only 1X. Only X like this. So the female will be created all right. but abnormalities a whole lot, because the 1X contains thousands of genes and they are all lost. It's deleted. We call it monosomy X. Do you understand? So the person will not be normal at all. Under development, the pelvic structures, the uterus, those things underdeveloped, like some wouldn't even form at all. Do you understand? So trisomy 21, you see the chromosomes are paired. So chromosome 1 is paired. Chromosome 1, chromosome 1. Chromosome 2, chromosome 2. Chromosome 3, chromosome 3. They are paired. Do you understand? So chromosome 21, they are paired. Instead of them to be paired, there will be additional one, chromosome 21 again, making them triploid. And that's what we call trisomy 21. Do you understand? That is Down syndrome. Instead of you to be paired, you are triploid. So you have added another chromosome which we don't need. So it is going to cause brain underdevelopment. The face, the head will be slim, slim head with flat forehead, like a whole lot. The brain will not develop well. Then the nerves will not develop well. So the person cannot walk straight, a whole lot. Is abnormal, Down syndrome. You have seen those people before. Those that they call Nsoba for, you have seen them. They cannot close their mouth all the time. Saliva is drooling like that. Trisomy 21. Trisomy 18, the same thing. Instead of 18, which is paired, there will be addition of another 18. Do you understand? So these are chromosomal issues. Anytime you see nuchal translucency measuring 3 mm and above, think of these conditions because these are the most common. Several studies have also demonstrated that the risk of aneuploidy increases with the thickness of the nuchal translucency. Yes, that's it. If you are getting 3 mm, you know it's cutoff point. So if even there will be a chromosomal issue, it will not be that severe chromosomal issue. When you get 5 mm, that is a serious chromosomal issue. Serious one. 6 mm, serious. Do you understand? So a lot of studies are saying that the increased the fluid at the back of the neck, the severe the aneuploidy. You understand? Please, is autistic? Yes, it's a chromosomal issue. Yes, autistic. Autism is a chromosomal issue. Yes, it's a chromosomal issue. I think you can read more on that. Okay, you can ask AI on which chromosome gets affected that leads to autistic spectrum or autism. It will explain them to you, but it's a chromosomal issue. Yes. All right. So, have you seen the back of the neck? This one, the focus is at the back of the neck, not the fetus itself. The back. Yeah, we just want to see the back of the neck, and this is the back of the neck. So once you get the fluid there like this, you measure. You measure. Have you seen the calipers? These are the calipers. One is here. Sorry, it should be straight. So you measure from top to down like that. This place up to this place. And you shouldn't get up to 3. Once you get 3, it's risky. If it goes beyond 3, then there is confirmation. But you wouldn't know that. Would it be Down syndrome? Would it be monosomy X? Would it be trisomy 18, which we call Edward syndrome? And we have the Fetal syndrome, which is trisomy 13. Fetal syndrome, trisomy 13. So Fetal syndrome is trisomy 13. So it's also common among the chromosomal anomalies. You understand? Okay. So that's the back of the neck. You just measure it once. This one, have you seen the back of the neck? Have you seen the fetus here? Very nice. Even though the image is zoomed. So the back of the neck, you can see the fluid. So you measure from this place up to this place. Okay. Nuchal translucency. This one, The woman understood, so they terminated the pregnancy. And have you seen it? Have you seen it? Have you seen how it is looking? Very bad. If you give birth to this, definitely it's going to worry you. You see, it's better you terminate it than to say that my prophet is saying, my pastor. Oh, Africa, I don't know. I don't know. We are not saying that spiritual intervention doesn't work. But you see, you and I know that the prophets of today, most of them, not all, most of them are fake. They will take your money, rip you off your money, and lie to you, and you give birth to these kids. And when you give birth to it, there is nothing you can do. And remember, most of them will not die. It's not like you are giving birth to it and it will die. Most of them will not die. They will live, even though some will die. But most of, like the Down syndromes, they can live long than a normal person. And it's going to create a whole issue. In your area, they will name your house. Oh, that house I are going like that. Meanwhile, it's just one chromosomal issue that you could have avoided it, like you could have terminated the pregnancy. This is not, you are not committing crime. There is a chromosomal issue. If you bring this child up there, and please, when you do the scan, it's not like once you are done with the scan and you say that nuchal translucency measures 4 mm. So the moment the doctor sees it, the doctor will tell the person, let's go and terminate it. Or no, they do what we call karyotyping. They do karyotyping. It's a lab test. They first do amniocentesis. They will withdraw some of the amniotic fluid and send it to the lab. Amniocentesis. Withdrawing some of the amniotic fluid and send it to the lab to do karyotype or karyotyping. And karyotyping is a lab test that goes into the chromosomal level and tell the particular chromosome which are affected. So if it says that there is no chromosomal issues, then that one we can stop it, so that the pregnancy can progress. Do you understand? But if it comes out that indeed there is chromosomal issue, it's better you terminate it. It's better you terminate it. Yeah. But it's not every patient that will get money for these tests too, because they are expensive. It goes into, it's like DNA kind of thing. It goes into the genes, the chromosomal level, so it's expensive. Right now, DNA crash, some parts of the country are taking 4,000, 5,000, 3,000 DNA. Yeah. So, yes, we can see this one, please. This is the CRL. I think somebody is writing something. Look, some place they are taking 6,400. You see? Yes. So the 3,000 I said, it's last 2 years. This year is expensive. So if you are going to impregnate someone, accept it. Don't say I'm going to do DNA. Meanwhile, you know it is you. Anyways, this is CRL, right? You start from here and you extend the measurement up to the ramp. That's CRL measurement, right? Now this is the nuchal translucency measurement. Have you seen? It's very tiny, so this is normal. Once you see this at the back of the neck, have you seen it at the back of the neck? One caliper is here, another caliper is here. The plus, they are the calipers. And the person got 0.15 cm. That means 1.5 mm, right? 1.5 mm. And 1.5 mm is normal. We are saying that it shouldn't go beyond 3. So 1.5 mm is normal. So the next chromosomal anomaly detection is tight amnion. I told you in the morning that the stationary sac is made up of this and this. What line is this one? What's the name given to this one? The outer line. It's called what? In the morning, I drew it on the screen. It's called what? The outer line. Oh, outer line, you don't know this. In the morning, I drew it on the screen. Can you guys hear me? And my network too is good though. It's not giving me any bad feedback here. Can you hear me? Or it's because
Yes,
of
sir.
the question I've asked that you're not talking. But in the morning I drew this on the screen. Hey, really? Amniotic sac or the amnion. Or the amnion. So the outer is chorion, the inner is amnion. Okay. Now, this is the amnion, which is the inner. And if you see the inner line, which is the amnion, wrapping around the fetus, we call it tight amnion. Actually, fetus, no. We call it tight amnion. And that's also a chromosomal anomaly. So when the amnion is too close to the fetus, in which the gestational sac is predominantly occupied by the extra amniotic coelom, and the amniotic cavity is tightly wrapped around the fetus. Extra amniotic coelom is where the yolk sac is found. Yes, I'll show you some images. So those fetuses are often at risk of a trisomy 16. Trisomy 16 can be very deadly. Trisomy 16 is fatal than the 21, 18, and 13. Trisomy 16, when you have it, there is the likelihood that the fetus will die in the uterus. If you're able to even give birth, it's likely that it will die. It will die. Because trisomy 16 doesn't joke at all. So you see the amniotic sac. This line is the sac. This line, that's it. It's wrapping around the fetus, and it comes here up to this place. Have you seen that line here? That's the line. Goes around it. You understand? Now, when you are scanning, you see that this fetus is static. It's not moving, because a fetus like this, if it's an embryo too, fine. And it is static. It's like something is attaching it tightly to the wall. So you probe further, you check it well, you see something wrapping it like that, wrapping around it. And that should tell you that it is called tight amnion. The amnion is tightly wrapped around it. Tight amnion. The amnion is very tightly apposed around the embryo. The embryo later was miscarried and was identified as what? Trisomy 16. Do you understand? It doesn't joke. Trisomy 16, it doesn't joke. It will cause miscarriage, or even if you are able to give birth, definitely it will die. Then we also have the 2-vessel cord. It's also a chromosomal anomaly. I asked earlier, how many vessels make up the umbilical cord? Somebody rightly said there are 3 vessels, and that's true. But here, the vessels in the cord will be 2, meaning a chromosomal issue. There is a gene on one of the chromosomes which is supposed to help form all the vessels. If that gene, one of those genes are deleted, some of the vessels may form, some may not form. Each of the vessels is assigned to a particular gene. So if the gene is deleted, that's it. It won't form. A chromosomal issue. So the presence of a 2-vessel cord can be a marker for aneuploidy. This is not typically searched for in the first trimester, but these findings can be recognized in a 10 weeks fetus. So in the first trimester, mostly they don't search this because the placenta is not that clear. I mean, even though you see it, but you don't focus on it. But about 18 to 23 weeks, that is when we do anomaly scan. 18 to 23 weeks. Don't tell me that, oh, I wasn't taught. I'm telling you today. Anomaly scan is done at 18 to 23 weeks. That's where we do anomaly scan. At that time, any anomaly, you will see it. Any anomaly that ultrasound is sensitive, you will see it. Do you understand? Don't go and search for anomaly at 10 weeks. 10 weeks, the structures are not fully formed. So one would look for a two-vessel cord if the fetus has other findings, such as thick nuchal translucency, for instance. So you are scanning this fetus. You are seeing that the back of the neck, fluid, you measured 6 mm. Go and check the cord. You check the cord, and you are seeing two-vessel cord. You see, everything is pointing to chromosomal anomaly. So 0.2 to 1% of all pregnancies present with a two-vessel cord. Among these, about 1 to 10% have an aneuploidy, including trisomy 18, 13, triploidy, and monosomy X. You understand? It can be any of these. It can be trisomy 18, which is Edwards syndrome, trisomy 13, which is Patau syndrome, triploidy. Triploidy means that the two pairs of the chromosomes are now, some of them are three like that. And monosomy X. Mostly the triploidy comes about when most of the time when the maybe two sperm fertilizes one egg. That one you get 69 chromosomes because this is bringing 23, this is bringing 23, this is bringing 23, 69. Yes, it's unusual for two sperm to fertilize one egg, but it happens. So when it happens like that, and the pregnancy survives, then it can be two-vessel cord. Mostly the pregnancy does not survive, and it will form molar pregnancy. The first semesters you may not understand, but you are going to treat it. Don't worry. I don't think I am the one who will teach you that one. That one is for the person who will be taking you for second and third trimesters. Yeah. Okay, so that is it. All right, so we are seeing color Doppler and energy Doppler demonstrating a two-vessel cord in a 10-week fetus. So even though it's a bit difficult to see with 2D, yes, but then yes, I suggest that always for you to say there are two-vessel cord or there is two-vessel cord, it's better you use Doppler. It's better you use Doppler because that can help you. You will see one blue, one red, meaning there are two. This one, yes, for me, I can see it, that two. But if you are not experienced, you can just use your blue and the red, put on it, put the color box on it, and then you see that it's either 3 or 2. If it is 3, you see these lines as 3. You see them not just 2. You see them to be 3. So we need 3, not 2. Now, yolk sac anomalies, several papers demonstrate that an irregular yolk sac or too large yolk sac can also happen. There are factors that are predictors of pregnancies that will end up in miscarriage in the first trimester. It's not juju. It's not juju. You can scan someone, and because of the yolk sac, you say it in your head, this pregnancy will fail. Because you saw that instead of yolk sac, instead of the yolk sac to be like this, you are seeing the yolk sac like this. Yolk sac like this, no, whatever you do, the pregnancy will fail. And yolk sac, instead of it to have this size, you see a yolk sac big like this. How can a yolk sac be big like that? It shouldn't exceed 6 mm. It shouldn't even get to 6 mm. So once you see that, it's an ominous sign. It means the pregnancy is failing. It's failing, unless spiritual intervention. But me, even though I believe in those things, but we are talking about medicine here. Yes, we are talking about medicine. We are not talking about, we are not prophets. So that is it. You should take note of such. Now, the presence of certain major anomalies should also prompt karyotype. I've talked about the karyotyping. Taking some of the liquor, or the amniotic fluid is called liquor. Taking some of it, send it to the lab. At 9 and 10 weeks, one appeared to have omphalocele. Omphalocele is the protrusion of the fetal abdomen, so that the process can undergo the development of the abdominal organs. Can form nicely. Then after everything is done, then it moves back into the abdomen. That is physiologic herniation. But if it occurs around 18 to 23 weeks, then we know that definitely there is what? Trisomy 18. That's Patau syndrome. Patau syndrome. You understand? But the 18 is Edwards syndrome, rather, not Patau syndrome. Edwards syndrome. One thing that we are saying is that even though the physiologic herniation is there, but you shouldn't see it throughout the pregnancy. It happens early in pregnancy, 10, 12, 11, 12 weeks there, 13 weeks there, like early like that. That's when the physiologic herniation happens. But if you see it 14 weeks, 15, 16, 17, you are still seeing that the stomach, the abdomen is in the liquor. No, that's a problem. That's a problem. And that one, most of the time, is because of Edwards syndrome, which is trisomy 18. Edwards syndrome. It's not all the time that is Edwards. It can be any other anomaly, a chromosomal anomaly. The other one had a large obstructed bladder and a small omphalocele, and indeed had trisomy 13. So research that some people did. Yes. They saw that one of the fetuses had large obstructed bladder, meaning the fetus cannot urinate. So the bladder is filled. What is the name given to enlargement of the bladder? More than 7 mm. What's the name given to that? Does anybody know the name? Enlargement of the fetal bladder measuring more than 7 mm. We call it what? It's greater than or equal to 7 mm.
Cystitis.
Again?
Cystitis.
Okay. So cystitis is inflammation of the bladder, not really enlargement. So you call it megacystis. 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 That's enlargement of the bladder greater than 7 mm. I'm talking about fetus, so not adults. Enlargement of the fetal bladder greater than or equal to 7 mm. That's megacystis. So the research found the large obstructed bladder. And indeed, when they tested for the karyotype, it was trisomy 13. Trisomy 13. That is the Patau syndrome, trisomy 13. Last one had a lobar holoprosencephaly. And when they tested, it was trisomy 18, Edwards syndrome. So we are saying that the fetal anomalies, they don't just occur. They occur because of something. Sometimes the chromosomes, the genes were okay, But the woman in first trimester, the woman will be taking alcohol. The woman will be taking unprescribed drugs. If you do that, some of these chemicals can hinder the activity of a gene, a particular gene, and that is all. In embryology, every structure is timed. Yeah, the time at also. Every structure is what? Timed. So if you are pregnant and right now, the time is 3:24. The gene has been slated. Maybe a gene for the ear has been slated for maybe 4 p.m. exactly. Between 4 and 5 p.m., the gene should be in action. By 5 p.m., the ear, it has, produced the ear. I'm giving an example. Okay. Then by 3:30, this woman goes and takes some medication. Oh, I'm sick, and takes an unprescribed medication. And the medication goes and inhibits that gene. And it's already 4:30. The medication is still working. 5, the medication is working. That is all. The gene will not work. So the ear will not be formed. When the time passes, it doesn't come back. It cannot wait for you to. So that is how chromosomal anomalies are. It is timed. Each structure is timed. It has a time that it should form. The gene should be working to create that. So if you do something, if you take something in and that thing goes and stop that, then that is all. Have you come across an adult who is about, let's say, 25 or 30 years, and the teeth, they are all brown? Every day, he or she brushes the teeth. The person doesn't have oral odor. Everything is okay, but the teeth, brown. Who has seen one before? Yes.
I've seen some before.
Yes. They are there. They are there. And you see that they like something that everyone is laughing, they cannot laugh. And it's not their fault. It was the mother. It was the mother. You are pregnant, don't take unprescribed drugs. Then she goes, and she goes and take tetracycline. That thing that they call red and yellow. Then you go and take. You see, the teeth, it is calcium and phosphorus that form the teeth. Red and yellow bind, its mechanism of action, it binds with calcium. So when you take, and they don't take it once too. If you take it once, sometimes it's okay. But it's contraindicated. You don't have to take at all. But they don't also take it once. They take it continuously, 3 times a day for 5 to 7 days. Hey. And as you are taking it, to be binding with calcium, and it will be deposited over there where the teeth will come. So the precursors of the teeth have already bounded with the calcium, and the color will change straight away. Once calcium binds with the drug, the color changes. And it will be forever. Unless you go and clear, you see the milk teeth will be brown. When the milk teeth are gone, the main teeth will be brown. So you have to go and change, you have to go and uproot all the teeth and get new teeth, artificial teeth throughout. Very bad. You understand? Very bad. So please, unprescribed drugs. When you are pregnant, don't take ciprofloxacin. Somebody will go and take without consulting any health personnel, and she will tell us that nurse if you are it's a nurse, a doctor, it's a nurse, a PA. Please, most nurses don't know the mechanism of action of drugs. They don't know. They have no idea. Most, especially the diploma nurses, they don't know anything when it comes to drugs. It is what the doctor has written that they are going to serve, even though they have to know, but they don't know the mechanism of action. So if you come to him or her and and tell her, my abdomen is paining me, and you don't, and she saw that you are pregnant too. But I'm saying she doesn't know the mechanism of action of that drug. She writes it for you. And you think a health professional has written it. Meanwhile, this health professional is not a prescriber. That person wasn't trained to be a prescriber. So it is in Africa that you nurses will be there, you'll be with nurses, and the family people are calling her, my child is sick, what should I do? This nurse. Hospital is there, send the child there, simple. Oh, there are some first aid that if it is emergency, yes, a nurse is there, you can call the nurse, yes, because they have been trained for such things. Do you understand? But not prescription of drugs, not prescription of drugs. A lab technician, the mere fact that he or she works at the hospital, then when your child is sick, you are going to him. My child is sick, what drug should I buy? And that is how they will come to you. My child is sick, what drug should I buy? They are not saying which hospital should I take him or her to, what drug should I buy? Hospital, you understand? So unprescribed drugs. So please don't, you the sonographers too. Yes, when you start working and you are wearing your white and the lab coat and go, your house people, they will think you are doctors. Hey, then you too, you don't know any drug. Then you pick a phone and you call someone, a nurse, and the nurse says, oh, go and buy this drug, and you write it for the person. If something happens to the person, if the person is pregnant, and maybe it is herself who is takes the drug, and something happens to her, the person will mention your name. You gave her that drug. That's why the person must come to the prescriber. The prescriber knows questions to ask before writing drug. So if a patient is sitting in front of me and complaining that passing loose stools, vomiting, and those stuffs, and I'm thinking that this is gastrointestinal issue, I have to inquire. The person is a female. When was your last menstrual period? Oh, for 2 months now, I haven't seen my menses. You see, I wouldn't be quick to go and write Cipro. You have to listen to the history, ask questions before you write medication. You don't just write medication for people. Some people are even allergic to Cipro. When they take Cipro, there will be rashes all over the body. Some people are allergic to diclofenac. When they take rashes all over the body. You need to ask questions. We don't just write drugs, so please don't just write drugs. Just because you were sick some time ago and a doctor wrote that drug for you. So when somebody complains that I'm having the same thing, then you write that drug for the person. Meanwhile, you are not a prescriber. So all that we are saying here is that first trimester pregnancy is like an unboiled egg. When it slips off your hand, it crashes on the ground. When I was teaching the weekends high risk pregnancy, abortion, when you go to abortion, see, I told them that in first trimester, even when you ride a horse, you are riding a horse, and you see the horse as it's running, you'll be jumping. That alone threatens the pregnancy. The next day you see blood, or next 2 days you see blood coming from your vagina. It is a threatening condition. So that thing that you did, and that activity that you did, it has threatened the pregnancy. So the pregnancy is telling you that I have been threatened. Don't do it again. If you are lucky, it wouldn't come out. Only the blood will come, little blood, and it will stop. So it means don't do it again. Sometimes, you see, most women, when they are pregnant, then they will be having sex. They'll be having sex. First trimester, stop having sex. It will come out. Because that's the commonest cause of miscarriage in first trimester is sexual intercourse. I'm telling you because they'll be coming to you. They'll be coming to you. They will come. Please, yesterday, I'm seeing, I've been seeing blood till today. How is it flowing? Oh, it comes drops like that. Okay. When was the last time you had sex? Last 2 days. Yesterday. This morning, like that. Like that. Those that will tell you that they haven't had sex, then their husbands are not close to them. Oh no, my husband is not here. My husband is in Accra. Okay, that's fine. So what did you do? Where did you go yesterday? Oh, I traveled. Was the road good? No, the road wasn't good at all. The jumping of the car, car or the motorbike causes threatened abortion. So first trimester pregnancy, I said and I repeat, it is delicate like an egg. Don't joke with it. Anything that will shake your body will threaten the pregnancy. So once you have threatened abortion, the pregnancy is still intact, but it is warning you. If you do any vigorous activity again, pounding fufu, sweeping a large compound, it will come out. It will come out because it has already threatened you. So you stop everything, having sex, stop it. Unless the pregnancy is 3 months. At that time, it has been stabilized. You can do what you want. Do you understand? Okay. Now, we are saying the holoprosencephaly. Holoprosencephaly is when, as the head is forming, you see the head has hemispheres. Let me clear the screen. The head, if this is the head has hemisphere. That's a division of the head. It divides the head into 2 equal parts. So this is left hemisphere, this is right hemisphere. For holoprosencephaly, this hemisphere may not be formed. We have 3 types. We have the lobar holoprosencephaly, alobar holoprosencephaly, and semilobar. I'm not going to teach you that here because we are not doing fetal anomaly, but I'm just throwing light on it. So you see that instead of this straight line from here to here, you can see just tiny line here. The rest will not form. Sometimes too, you will see the line here. The rest will not form. Sometimes you see the line here. The rest will not form. Do you understand? So it's about development of the brain structures. We call it prosencephalon. That part I'm talking about, prosencephalon, the forebrain. So the forebrain, part of it may form, part of it will not form. Sometimes it will not form at all. So the one that part will form, part will not form is called semi-lobar. The one that will not form at all is alobar. So when you get to anomaly ultrasound, the person will teach you. So that one, when you see holoprosencephaly, we are thinking of trisomy 18. That is Edward syndrome. Edward syndrome. So have you seen, there's a fetal abdomen? Have you seen the abdomen protruded? Have you seen the protrusion? Have you seen it? Have you seen the protrusion? That's the abdomen. The fetal abdomen has protruded. On follows at 9 weeks. So at this stage, is it physiologic or pathologic? Who can tell me? 9 weeks, and we are seeing protrusion of the abdomen. On follows, that's protrusion of the fetal abdomen. Is it physiologic or pathologic at 9 weeks? Hey, please, I've explained this. I have explained this to you. At 9 weeks, when you see the herniation, is it physiologic or pathologic?
Pathologic.
9 weeks, okay. But why do you think it is pathologic?
No, it should be physiologic because it's
okay.
Going to.
All right. So that should be physiologic herniation. Physiologic herniation. It will move back. So when you see omphalocele cell at this stage, and most of the time you will see it too. It's not like you won't see it too. You will see it. You will see the omphalocele cell, protrusion of the abdomen. You will see it. When you see it, write it. But your impression should be what? Physiologic herniation. So there should be a repetition of what? Scan. So at if 9 weeks, 10 weeks, 11, 12 weeks, you will see this physiologic. Even 13 weeks, you cannot just say it's pathologic. That's why I said anomaly scan is done at 18 to 23 weeks. That's the time you confirm whether it is pathologic. At that time, when it is still there, then it is pathologic. 18 to 23 weeks. Do you understand? If it is still there at that 18 to 23 weeks, then it is trisomy 18. This is megacystis secondary to posterior urethral valve. I've already told you megacystis. What did I say about it? What is megacystis? It is what? It means what?
Enlargement of the bladder.
When it measures
greater than or equal to 7 mm.
Exactly. Greater than or equal to 7 mm. That is megacystis. So this is the fetal bladder. That's the fetal bladder. So that's the head here, the neck, the chest, the abdomen. Then the lower abdomen is where the bladder is. So this is the fetal bladder. When you measure, you stand here, you get it well bordered, and you measure up to this place. You get more than 7 mm, definitely. Once you get that, it is megacystis, because fetal bladder shouldn't be big. This one, if you don't measure, you even know it already, because this is too big. No, it's too big. Fetal bladder is mostly like this, and sometimes like this. Once it gets to this, they will urinate, then it will shrink. So fetal bladder shouldn't be like this. It's too big. Do you understand? So that is megacystis. Secondary to what? There is something obstructing the bladder. That's why the fetus cannot urinate. So if this is the bladder, the urethra is here in the penis. So the urine should flow, but there is something here obstructing the urethra. So the urine cannot come out. Mostly strictures. When there is stricture, strictures means formation of fibrous tissue blocking the cavity. So we call that blocking the entrance into the urethra. We call that posterior urethral valve. Normally, there is a valve. If this is the urethra, there is something like a vein shape here before the bladder can start like this. You understand? So the urine will come here. When it gets here, the vein shape will open here. It will open, and the urine will come down here. But there are some instances that this vein shape, which is the sphincter, will develop fibrous tissue. So it will be fibrotic, hard, and it can't open like this. It will be hard, blocking the cavity here. It can't open. So it means that the bladder is filled by the kidneys, and the fetus tries to urinate, but the urine doesn't go out because of the strictures over here. So the bladder keeps enlarging because urine is being produced inside from the kidneys, enlarging. Please, if it keeps enlarging, what will happen to liquor volume? Liquor, the fetus is drinking the liquor. When the fetus drinks, it should pass in, it should be absorbed, and the kidneys will filter and produce urine so that the fetus urinate into the liquor again, so that the liquor will maintain its volume. But there is a situation that the fetus is drinking, the kidneys are producing the urine. The fetus is drinking, the kidneys are producing, but the fetus cannot urinate. What happened to the liquor volume? Who can tell me? What happened to the liquor volume?
Sir, it will decrease.
Exactly. So the liquor volume is going to be reduced drastically. That is one of the causes of what? One of the causes of oligohydramnios. You are not the first semesters, you are not there yet, so I wouldn't confuse you. But Lower liquor volume, we call it oligohydramnios. You understand? That's the mechanism of the fetus drinks and urinates into it so that it maintains the volume. Drinks, urinate, and the drinking, there are proteins in the liquor that helps with the lung development. That helps with the fetus itself to develop. There are proteins in the liquor. That's why it drinks and urinates, drinks, urinate, drinks, urinate. Do you understand? So if it is drinking, it cannot urinate, then the liquor will finish. So low liquor volume is called oligohydramnios. It is not oligohydramnios, it is oligohydramnios. That's what most sonographers make the mistake. They mention it oligohydramnios. So when they are spelling, they bring I here after the M. Please, there is nothing like that. It is oligohydramnios. And when the liquor volume, okay, what if the stomach is also blocked? The stomach is blocked. Let's say the esophagus. The esophagus is blocked here. So the fetus cannot swallow. What happened to the liquor volume? The esophagus is blocked. The fetus cannot swallow the liquor. What happened to the volume?
The volume will be more.
Yes, the volume will be more. So there will be what? Polyhydramnios, isn't it? Polyhydramnios.
Yes,
Let me check because I have class at 4. Let me check if they have put a message on the page already. Okay, not yet. Okay, so it will be poly. Then you add the hydramnios. That's it. Okay. You like we are going to treat all these in the second and third trimesters when we are able to finish this one today. When we meet again, we'll talk about it. So there is the lobar holoprosencephaly. You can see that all this part of the brain didn't form. There is the head. So all this part of the brain didn't form. It is occupied with what? Fluid. So only this part of the brain formed. This part, if it had come down here up to this level, that means that it has divided the head into two. So you cannot call that a lobar. You call that lobar because from here to this place, then it is lobar. But this is a situation that half of the division is gone. So fluid all over. So you call this a lobar. A lobar. Even sometimes this can also be called semilobar. Yes, it depends. The last part of this presentation is shapeless embryo. Shapeless embryo is when you are taking the scan. The age with the age of the gestation, let's say it's about 13 weeks. You expect to see the head, the neck, the chest, the abdomen, the legs. You expect to see all those things, but at that, let's say 18 weeks, you are not seeing those things. You are not like you don't see the thing properly. You are unable to differentiate the head from the chest, from the abdomen. You can't. It means it is shapeless. It's also a chromosomal anomaly. It's coming from chromosomal issues. So a shapeless embryo is an embryo with no distinctive head and body at the time when these findings should be recognized. You understand? So this can be a sign of what? Various trisomies, usually very later trisomies such as trisomy 8, 16, and triploidy. So these trisomies, they are very deadly. I've talked about the 16, very deadly. 8 is also deadly. When you have trisomy 8, you cannot, the pregnancy cannot survive. So that is it. And when we meet again, we will talk about the problems in first trimester: incomplete abortion, missed abortion, unembryonic gestation, intrauterine bleedings, that is with abortions, ectopic pregnancy, and then gestational trophoblastic disease. So we'll meet our schedule for our meeting again, and then we do these things and finish with the first trimester before we move to the second and third. Please, any question? So I expect you, from today, I expect you to know all the chromosomal signs that when you are scanning and you see, you know this is likely a chromosomal anomaly. So you request for karyotyping or amniocentesis for karyotyping. You understand? They have to withdraw some of the lipo, send it to the lab for karyotypic examinations. Okay. If there is no question, I'll end here. And then we for the first semesters, and then Emmanuel. Okay, Emmanuel's class. I'll meet you on Sunday. For the first semesters, I'll call you. Yes, the class rep, I'll call you. But Emmanuel's class, I'll meet you on Sunday, 5:30 a.m. So take note. So we'll communicate. All right. All right. Have a nice evening.
Yes, sir. Yes, sir. Thank you, sir.